Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with operating in Alice Springs and the greater Barkly region. I would first like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Arrernte people of Mantua. We recognise their custodianship and their continuing relationship with the country, and that we work on their stolen lands. My name is Dr Indi and today I'll be talking to Dr Kirsty Neal. She's a consultant endocrinologist based at Alice Springs Hospital.
Hi everyone, thanks for having me, Indi. I've been here for 4 years. I came here for my final year of endocrine training and we've stayed here, as is the story for many other people. I've got 2 kids, a husband and a dog, and we've just bought a house here. I also work in general medicine at the hospital in addition to endocrinology.
And I've worked with Kirsty in the hospital and we've been doing all sorts of general medicine. But the main reason I wanted to talk to Kirsty today is about type 2 diabetes, which we see all the time in Alice Springs. So, Kirsty, how much of a burden of disease is diabetes, whether that be type 1, 2 or type 3 in Central Australia?
I'll touch on type 1 first because it's quick. We've actually got a really high rate of type 1 in Central Australia, but it's not more than the average nationally. We've got 200 patients with type 1 diabetes, of which we know about 100 on the books. So that's quite a lot for when we've only got 0.5 endocrinologist here. Type 2 diabetes, we've got the highest prevalence in the whole entire world. That statistic came out in 2022 with Dr Matthew Hare. Of Indigenous Australians, it's around 40% of adult Indigenous Australians have type 2 diabetes. The national average is around 5 to 8%, depending where you look. The other highest recorded numbers were sort of in the high 30s in these sort of 1970s populations in the Arizona desert and the Pima Indians, and another high level in the Marshall Islands. It's fairly high levels in some areas in the Middle East as well, but nothing that meets this. This is a diabetic state of emergency. We have not only high rates, but high severity. So the average HbA1c at diagnosis is much higher, but also people are getting diagnosed a lot younger. So people in their 20s, 30s are being diagnosed, and as young as five years old in Central Australia. One of our beautiful GPs, Dr Hang Murphy, has done a bit of looking into our youth diabetes, and it's quite alarming. They've got 49 kids in the Central Australian Congress clinic, so that's local to Alice Springs. This doesn't include the remote clinics. There's 49 kids on their books who've got type 2 diabetes under 16, and on average they were diagnosed at age 12. And of those, their HbA1c median was 12.5%. and the highest was over 18%. They then followed those kids after a year and on average they got worse by 2.5% by their HbA1c. So we're not doing enough to support these kids.
So young onset diabetes is something I was going to ask you later in the episode, but we might as well touch on quickly now. Do younger diagnoses of diabetes or type 2 diabetes get a different name? I've heard of MODY and LADA. Can you talk a bit more about that, Kirsty?
So in Central Australia, we've got a different sort of phenotype of type 2 diabetes. Anywhere else in the country or even the world, if you're seeing a kid at the age of 5, 10, 12, 16 even, with such high numbers, or even with any diabetes really, you'd be looking for other types of diabetes like type 1, MODY, LADA, etc. These are autoimmune diabetes. You'd be looking for pancreatic problems. Have they got cystic fibrosis or something else that's damaging their pancreas? In our patients, unfortunately, it's this intergenerational diabetes. So the mum who's had diabetes in pregnancy, the grandma who had diabetes in pregnancy, the baby in utero was making the ovaries of the next generation. So this intergenerational diabetes, people are getting younger and younger. And so we're seeing these people with type 2 diabetes and they're more likely to present with diabetic ketoacidosis. There was a neat study that looked at about a third of these young people with type 2 diabetes were actually diagnosed on presentation to hospital when they had diabetic ketoacidosis, which doesn't necessarily mean they have type 1 diabetes, but anytime someone who's young and presents with diabetic ketoacidosis, we do need to think about that and rule out other types of diabetes. I'm a little bit on the fence about testing for these monogenic diabetes in youth because I think it's important because it can change your management and screening, but we've got kind of bigger fish to fry. The testing is $1,200 per person, and I'm not sure that it makes a huge difference to treatment at this stage. But I think we should be offering the gold standard of investigations, and I don't see why that doesn't apply to our patients. But I'm still a little bit undecided on that one.
And just to explain for the listeners, MODY means mature onset diabetes of the young and LADA means latent autoimmune diabetes of the adult. And presenting with diabetic ketoacidosis as a type 2 diabetic is something that we'll also touch on a bit later in the podcast. So, Kirsty, with our high prevalence of type 2 diabetes in Alice Springs in Central Australia, the highest in the world, as you said, what's the difference in management here? Maybe we'll just run through what normal type 2 diabetes management is and then how it is different here based on the age differences, the cultural differences, and if you could just speak to that.
Thanks, Indi. Yeah, look, I also want to mention about the statistics. In the hospital, the prevalence of type 2 or any diabetes is over 60%. So in those over 35, if you're Aboriginal, it's above 80%, and the highest rates are between 45 and 55 is 89%. So you're going to see, you basically need to assume that every one of your patients has diabetes until proven otherwise. And so the first thing is check the patient's sugars if you're working in the hospital. My opinion is that the most of diabetes should be managed by primary care, but patients come to hospital in 6 states where their sugars are higher than they would normally be because of the fact they're sick. You make your sick hormones, which is cortisol, that makes you insulin resistant. People, when they feel sick, don't take their medications, which exacerbates the sugars. But we know that high sugars relates to complications with infection rates, fluid overload, etc. You know, if your sugar is 1 millimole above the average range, every 1 millimole is about 10 to 17% increase in infection rate. So it's really important to manage the sugars in the inpatient setting. The difference in management here, I think we really need to talk to our patients, and that's the most difficult thing because we don't have time. It takes time to sit down and listen to your patients and get their story. And I think the best thing we can do is use Aboriginal liaison officers. And again, that takes time because it requires a phone call. You then have to wait for them to be available. Maybe the person who speaks that language is off sick. But I think it's still really relevant, even if they don't speak the language, to get that person to come get some cultural buy-in so that your questions aren't just answered with yes, 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 or no, 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 or something that's meaningless, because we can prescribe medications. That's easy to do. That takes 2 seconds. To actually engage with your patient and work out what's right for them is a different story. So asking people, have you tried medications before for your diabetes or for your sugar? And they say yes, no. Did you feel sick on those? Did some of them, were they hard to swallow? We've got a lot of women of childbearing age who are on medications, and we don't usually consider this in patients with diabetes because they're usually older patients. But asking patients, are you planning on pregnancy? Are you pregnant? And then counselling them when we're making their treatment plans. So there's a lot of issues with adherence in communities for various reasons. People may not have places to keep their medications. They might be prescribed a daily insulin. They don't have a fridge to put their insulin in, or they don't have the dexterity to use it, or they don't know how to use it, or there's big shame job around using insulin because it's more of a visible medication. So we need to be conscious of those obstructions to prescribing insulin. And quite often people go back to their clinic, their sugar's 24, 28. GP reflexly increases their insulin dose, but actually the story is that they're not taking it. So the first thing about management plan is asking what's worked, why hasn't it worked, do you even want medications? And I think these new weekly injectable medications have really changed the landscape for therapy in Central Australia, but probably for the whole of the world. But we're having supply issues with those at the moment. The other thing is with the weekly GLP-1 analogues is really counselling patients that it might make you feel sick, but please persist, lower the dose if you need to, go up more slowly. If they're on maximal dose of a GLP-1 agonist such as semaglutide, also known as Ozempic, or Trulicity, which is dulaglutide, they haven't had it for 3 months because of supply issues, don't restart them on the high dose again because they will vomit for a week. They'll turn up in ED, they'll get many CT scans. So just go back to the starting dose and gradually up again. So a lot of people have contraindications to these meds from side effects from previous times, but exploring what those side effects were and maybe weeding out, actually, was it just a dose adjustment issue? Because these drugs have really changed what we do in type 2 diabetes in Central Australia. The sort of mainstay of treatment for anyone with diabetes, we start with diet and exercise. And the classical training is start with that, add in a medication, usually metformin. Metformin's natural, by the way. It's from the French lily. You can tell your patients. You start with that. Technically, we used to train that wait for that to fail before you add in the next thing. And then you'd add in what's normally would say a sulfonylurea, such as glycoside. I don't like sulfonylureas because they're obesogenic, and they're the only oral medication to cause hypos. So I would suggest going hard early. So if someone's got an HbA1c of 10%, starting metformin and advising them to exercise is not going to work. When you're starting metformin, you've got to start on a low dose. I dare you all to try a little bit of metformin. It makes you feel sick. I tried 500 milligrams once. I felt sick on it. And we're asking our patients to sometimes just take 2 grams up front because they've been prescribed it in the past. That's what they're on. So you need to go slow from when you re-prescribe it, and it doesn't work immediately in the hospital. It takes weeks to months to up-escalate the dose and for it to take effect. So in the hospital for type 2 diabetes, things that work immediately are insulin and sulfonylureas, which is glycoside, but be mindful that they can also cause hypos.
So Kirsty, if I'm an intern on the surgical ward, the medical ward at Alice Springs Hospital, and someone's got a BGL of 18, should I be worried? Should I start them on metformin? If I'm the first healthcare professional this person is coming into contact with, is it my responsibility to start them on something that will lower their sugars and prevent them from having all of the sequelae of hyperglycemia?
It's a good question. Yes is the simple answer. It is your responsibility. You've picked up a very abnormal result. And yes, it's your responsibility to do something about it. And if you don't know what to do, the first step is to look up the Australian guidelines. Australian Diabetes Society has a really excellent flow chart of how to start medications, and they've got a really detailed document on how to start it on inpatients as well. The second place you could go is therapeutic guidelines and check out what they've got. We've got it through the hospital access library. We get complacent with sugars of 18. Sometimes we worry when they're above 20, or the nurses worry and they let us know about it, and then we're sort of like, oh, that's normal for that patient. But we've become complacent to that, and I don't think that's good enough. I think we really need to actually go, yes, I need to do something about this. And at the end of the day, if you don't know what to do, or you're so busy that you don't have time to look up the guidelines, which is usually what happens, is pick up the phone and call the medical registrar. They should be able to help after hours. If it's during the day, pick up the phone and call the endocrine registrar. They should be able to just help quickly over the phone on how to start something simple. If it's 18, it's in the hospital, they've just had surgery for their finger laceration, for example, metformin's not going to do anything in the next couple of days. So for that person, you might want to give a stat dose of insulin, you might want to give some glycoside, you might want to think about, are they on their usual medications, and if they're not, chart them. But you do have to do something. And then if you're starting insulin regularly, you need to have an exit plan off insulin if they're not normally on insulin. So you don't just chart it and then on the day of discharge scratch your head and go, oh, what do I do with this? I'll just stop it and put them on whatever they were on before. So you need to have a bit of a thought about an exit plan early, and that might be that you ask someone else for help. If it's 18, it's probably going to be high across the board, fasting and postprandial. So you need to think about, great, I could give 4 units stat of a quick-acting insulin like Nova Rapid, which is the only one we use subcut in the hospital for these sorts of things. You could just do that, but there's going to be a problem in 4 hours' time when it goes back high again for the next person who's on, or maybe yourself later in 4 hours' time. If in 2 hours' time you've given 4 units, for example, and their sugar's now 20, you need to do something else about that. You could give another dose of 4 units, for example. And working out the dose is quite tricky as well, but you can base it on their weight as one way to do it. So ETG says 0.5 to 1 unit per kilogram per day. So for a 100 kilogram person, that's 50 to 100 units of insulin per day. You break that up into basal bolus, which is 50-50. So 50% basal, 50% bolus. Bolus meaning with food or, extra bits of short-acting insulin. So the basal will be 25 to 50 units. So you'd be safe to start that person on 25 units of basal insulin, such as glargine, and then you could give easily a stat dose of somewhere between 6 to 16 units of insulin to bring their sugar down. If they're much lighter, they're going to be a lot more insulin sensitive, and you're going to use lower doses based on that. You can also, if they're already on insulin, you can work out their total daily dose of insulin and do some calculations based on that. So the more insulin someone's on, if you give 2 units and they're on 100 units of daily insulin, it's not going to touch the sides. So you're really going to have to give them a bigger dose, 10, 15, 20 units of insulin to bring that sugar down.
And if I'm worried that my patient that I've newly started on basal bolus insulin might not be compliant or adherent outside of the hospital with injecting insulin subcutaneously, is there a role for once daily basal insulin?
If they're going to take it, and this again comes down to talking to your patient, and you may not have the time to talk to your patients, you might be busy with other things, you may not know how to ask those questions. And if you feel comfortable, great, but if you don't, this is where you get a diabetes educator to come in and really trying to tease out barriers to treatment. With our population, there's a lot of issues with food security, understanding timing of insulin, which is really important if you're having a mixed insulin or a basal bolus regime. Just to clarify, basal bolus means you're giving a long-acting insulin, and then separately usually with meals you give your short-acting insulin. You've then got mixed insulins, which you inject at the same time together, and they're at fixed ratios. And so if you're like randomly injecting Novomix or Ryzodeg, which are mixed insulins, at a time that you're not eating, the component of Novorapid, which is about 30%, might actually give you a hypo. In our patients, they usually run with such high sugars, it's not a problem, but for people who are quite insulin sensitive, it can be quite dangerous. And so basal insulin ends up being kind of what we end up doing really because of that food security. But again, it comes down to a particular patient, and we should never assume that they're not going to adhere to your regime if you give the right education. But if you do get that education and you think it's going to be a safety issue, then I would just give the daily basal insulin.
So, Kirsty, you already mentioned one scenario in which we would consult endocrinology, which would be high blood sugars and considering starting them on their first agent. When would be some other times in the hospital as a junior doctor I would consult endocrinology?
So I scour the wards when I'm on for endocrinology, up on particularly the what we call the Wild Wild West on the surgical wards. I scour the bedside folders and looking at the blood sugar levels, and anyone who's really got sugars that are averaging above 10, I would sort of look into why and maybe go talk to the team and say, hey, are you aware the sugars are high? Do you want some help to address it, etc.? So anyone really who's got, on average, sugars above 10, if they've got a random sugar sort of 10 to 15 and everything else is sort of 5 to 10, don't really care. But if they're regularly on something 10 to 15 and either you don't know what to do or what you've done hasn't worked, then you would call endocrinology. If you're really not sure and you're flat chat and you just can't work it out, I would call endocrinology at that point as well. We've got quick answers for you on the end of the phone. We don't necessarily need to see your patient, but we can give you help on the end of the phone quickly.
And would there be any diabetic emergencies that we would be calling you for? Would we be expected to manage them as a junior doctor alone? For example, you mentioned diabetic ketoacidosis in type 2 diabetics. Can you speak more to that?
Most diabetic emergencies will happen through the emergency department. As a junior doctor, you wouldn't be expected to be managing it alone, but you'd be expected to pick it up. And so if you've got a patient who's just generally unwell, as a lot of our patients present, they're fatigued, lethargic, they might be dry, they might be wet, they've got high sugars, they might have normal sugars because they might be on an SGLT2 inhibitor. And if they are on an SGLT2 inhibitor, think about checking their ketones. So if you then check their sugars and they're high and they've got either what's called hyperosmolar hypoglycemic syndrome, or they've got diabetic ketoacidosis, that's where the ketones are above 3, they're acidotic on their VBG and they have high sugars, then that is a diabetic emergency. I'd be involving seniors very quickly. The main difference between what's called HHS, the hyperosmolar hypoglycemic diabetes syndrome, is that they're usually type 2 diabetes, and they've usually had higher sugars for a more prolonged period of time, and there's usually a much more severe insult that's caused that high sugar. So they might have had a heart attack or sepsis or something like that, and they have a much poorer prognosis, and that really is an emergency. Some studies quote up to 40% mortality with this syndrome. Some others quote down to about 5%, but it's somewhere between probably 5 and 40%. So it's quite a serious syndrome. They're usually up to sort of 10, 12 more litres deplete in fluid. And so really fluid replacement is the standard of management and treating the underlying cause of that problem. Look for the heart attack, do an ECG, look for the infection, do blood cultures, get your inflammatory markers, etc. And if they're elevated or they've got a fever, just treat on spec. For type 1 diabetes emergencies, they can happen a lot more quickly. So they might have either they've missed their insulin for some reason, their insulin's cooked by the sun, they've got a pump malfunction, they've also got an infection and they don't know how to do their sick day management, or they do and it's not working. This can happen within hours to days. So usually they're not as unwell and their reversibility is much greater, so they get quicker a lot better, and you sometimes see these awful pHs of 6.9, and never is that really compatible with life, except maybe in DKA with type 1. These guys need fluid. They're usually only sort of 5, 6, 7 litres deficit of fluid, but they also need insulin quite quickly, so you start their infusion straight away, as opposed to those people with HHS, you might really give fluid initially as a resuscitation and then start the insulin infusion a little bit later. Well, not that much later, but the fluid resuscitation is really important and fixing the underlying problem. For type 1 diabetes, if they're on a pump, it's really important to get the endocrine team involved early, because getting them back on their pump is really important, because that's actually the best day of management. But if they are on a pump and it's failing, just put them on an insulin infusion, and that really should be more senior staff involved on insulin infusions. So I expect people to check sugars, recognise a sick patient and look at their medical chart. Have they got a history of type 1? Yes. Well, there could be a DKA, check the ketones. History of type 2, always check the sugar anyway, and if it's high and all the other things are happening, consider HHS because it is a medical emergency. And then I think hypoglycemia is the other medical emergency. I don't really care if it's above 3, to be honest. Anything below 2.5 is probably something you need to do something about now. And if they're not tolerating oral, you can give 50% glucose, 50 mils. If they're type 1, just be careful about overshooting the mark because then you'll be chasing their high sugars all day. But anyone in a hypo, you really need to treat straight away as well.
So thanks for talking, Kirsty, about the diabetic emergencies. I think I'll change tack to how we would manage diabetic medications in a fasting patient. I think that's very much the role of a junior doctor and sometimes not checked by your seniors and expected for you to do. Just going through, I guess, the mantras of perioperative or fasting diabetic management.
Thanks for asking. Our lovely recent registrar just updated our guidelines, and they now include GLP-1 agonists and SGLT2 inhibitors, which are really important in the fasting patient. But generally speaking, it depends on the patient and what their underlying glycemic control is. So if you've got a type 2 diabetic with really good control, then generally if they're on insulin or something that causes hypos such as gliclazide, then you might halve their long-acting or their basal insulin or their gliclazide. If they've got terrible control and they don't take their meds, you might actually give a little bit of that medicine to bring their sugars down so they don't end up on an insulin infusion. If they're on an SGLT2 inhibitor, that needs to be withheld 3 days prior to fasting or operations. Less than 2% of our patients actually are having elective surgeries in our hospital, so that's never really something we need to sort of plan for, and they come in on these medications. If they come in on these medications and they need to go get their finger washed out or their abscess drained or whatever it is, check their ketones. If their ketones are above 1.5, check their VBG. If their pH is low or they're acidotic, you need to do something about that. And I would probably start an insulin infusion for the operation at that point and not discontinue that infusion when they go to the ward and then contact the endocrine team. A lot of the anaesthetists or the teams just stop that when they get to the ward and the problem continues for another up to 3 to 5 days. So we need to be quite cognizant of the continuing effect of the SGLT2 inhibitors. If they're on SGLT2 inhibitor and their ketones are under 1.5 and they're generally well, and their sugars are a little bit high, you could probably get away with some subcut insulin, a long-acting variety. And I would go big dose. I'd stop all their other medications so you can give a big dose of insulin. And then you could put up a glucose strip. If they've got terrible access and you're worried that glucose strip is going to fall out for some reason, I'd go a little bit lesser on my insulin dose from the start point. But if you know they've got good access or they're easy to get a cannula in, you could give something, like a higher dose, like 40 units, for example, of glargine and then trickle in the drip. And that will clear the ketones and stop them from going into acidosis. In terms of metformin, it's pretty safe to give unless you're giving contrast. So we withhold 2 days around contrast because it can increase the risk of lactic acidosis. I have seen it in our population. A lot of endocrinologists say, I've never seen it. I have seen it. Whether it's due to the metformin or other, I have no idea. I mentioned gliclazide. If they're well controlled, I'd halve it. If they've got terrible control, you might actually want to give it. The problem is that they don't get any of their morning meds because the protocol says withhold all orals, et cetera, et cetera. They come out of theatre in the afternoon. They end up eating all their food. It's 10 p.m, you're their intern on in the evening and their sugars are suddenly 30. Like, what do you do? So really having that thought about it beforehand is important. And it might be that if they're on the morning list, you might just give their morning medications if they're eating and drinking after theatre when they come back up to the ward. But having that charted and a plan ready to go is really important. And quite often you're doing these plans when they come in at midnight and you've got no one to ask but the MedReg is busy. So please refer to the protocol. It's a really good one. I've pinned it up in the surgical office. Hopefully it's still there. If it's not, I'll go check next week. In terms of the gliptins, which are the DPP-4 agonists, they're not very strong. They're completely harmless. Don't need to discontinue them for surgery. Keep going on them. They don't cause hypos. As I said, the only oral that will cause hypos is gliclazide or your sulfonylureas. If they're on a mixed insulin and they still need a little bit of insulin, split them into their basal bolus component. So if they're on Novomix or Ryzodeg, for example, they're both 70-30 mix, so 70% long-acting. So if they're on, for example, 50 units of Novomix, 70% of that is glargine, which is about 34 units-ish. You'd give depending on their control, 34 units of long-acting insulin. You might give a little bit less because they're fasting. When they're eating, you might give a little bolus of Novorapid with the food. I always chart a supplemental scale, also known as a sliding scale, but if we're getting down to semantics, it's supplemental, for patients peri-op as well, just in case they're high. And again, that's based on their weight, generally speaking, or their previous insulin resistance, if you know it. So if someone's tiny, I'd be prescribing little doses, 1, 2, 3 unit doses. If they're big, you might be prescribing 10, 20, 30 units potentially. A generic sort of response would be 2 units if they're above 10, 4 units if they're above 12, 6 units if they're above 14, etc., and going up sort of in that respect. And being careful if they're still on a restricted diet after their surgery and reintroducing their medications.
Yeah. Thanks for explaining that and going through the sliding/supplemental scale. I think we're getting to 20 minutes. Okay. Okay, so for my last question, Kirsty, I would like to ask you about type 3 diabetes or type 3C diabetes. This is something that we see on the wards in Alice Springs and something I hadn't heard of before coming to Central Australia. I think it's one of those unique medical conditions that happen here. I'm aware it's caused by pancreatitis, chronic pancreatitis. Could you speak to that as well?
Yep. So we do have really high rates of type 3C diabetes. I just want to comment on the nomenclature of this. So there's many different nomenclatures of this. It's technically called diabetes of the exocrine pancreas, which I don't like because it actually involves the endocrine pancreas, which is your insulin-secreting cells. But it's really important to acknowledge that this also affects your exocrine cells, which are the ones that release your pancreatic enzymes, lipase and amylase, for example, which are involved in breaking down your fat-soluble vitamins A, D, E and K. These patients will often... So back to the nomenclature, Type 1 diabetes is the autoimmune variety. Type 2 is your insulin-resistant variety, and type 3 is everything else. Within type 3, you've got A, B, C, D, down to about G, I think, and that includes all types of other diabetes, such as gestational diabetes, steroid-induced diabetes, leprechaunism, thyrotoxicosis, etc. And type 3C specifically is anyone with pancreatic damage. It could be that your pancreas has been removed from cancer or other reasons, cystic fibrosis patients who get a damaged pancreas over time, but more commonly, as you mentioned, Indi, in our population, it's often due to chronic pancreatitis. And there's some literature that suggests our patients are more predisposed to pancreatitis due to alcohol and other issues such as gallstones and other. And we're not quite sure why, we don't quite understand that, and there's probably a genetic predisposition. There's a bit of work going on in this space. We know that a lot of Indigenous people have a lesser amount of nephrons in their kidneys, which is why they're predisposed to diabetic nephropathy. And there's probably something similar in the pancreas happening as well. We should think about it in our patients who are skinny, are big drinkers, or they have chronic pancreatitis, who are not responding to oral medications, and who actually only require a little bit of insulin, and that might even give them a hypo. So they're usually very insulin sensitive and usually quite slim. And quite often, given the stats on our patients, they had type 2 diabetes before they developed this type 3C or diabetes of the exocrine pancreas. So the labels might be type 2, but don't be dismayed by the label. If you've got a skinny patient who's only requiring a little bit of insulin, or they're ketotic really quickly, or they're acidotic even, think about type 3C. The diagnosis, we need to prove that they're insulin deficient. So you'd measure a C-peptide with a matched glucose. The reason you measure a matched glucose is because if your C-peptide, which is when the pro-insulin cleaves into insulin and C-peptide, we can measure the C-peptide as a sort of a measure of insulin. If you measure insulin in the serum, you're just going to measure the insulin you've just given potentially. So C-peptide is a bit easier to measure. If your sugar is 4 and you're not making much insulin, well, that's actually appropriate. But if your sugar's 20 and you're making not much to a little bit of insulin, that's inappropriate. So if you've still got a normal C-peptide but your sugar is 20, that's inappropriate response, even though the lab range says it's normal. So you need to measure it with a matched glucose, which is really important, and that should be sent off in a grey tube, or you can do it in the purple tubes for your full blood count, but that needs to go straight to the lab because as soon as it needs to be measured within 15 minutes because the cells start releasing or using sugar or something like that. So that's really important. But keeping in mind, just because someone has a low C-peptide at diagnosis doesn't mean that they're always going to be insulin deficient. There's a concept of glucotoxicity, which is someone who's got high sugars for several weeks or longer at a time, and I'm talking very high sugars, 20s, 30s, etc. It's actually toxic to the beta cells which make your insulin in the pancreas, and it can switch off beta cell function intermittently or temporarily, so it kind of stuns the pancreas. If you get that person better control with medications, whether that be insulin or other, and then you remeasure their C-peptide sort of 2 to 10 weeks down the track, they actually might have a normal insulin response to sugar. And so, to say just off one blood test you're committed to insulin for the rest of your life, you've got type 3C diabetes, is quite a big deal for a lot of our patients. And if you do have type 3C diabetes, especially our patients here, they've got terrible dexterity quite often from chronic nerve damage to their hands. They might have poor eyesight from retinopathy. And using insulin can be a real problem. Like, you can't dial it up. You can't see what you're dialing up. You may not be able to hear the clicks on the insulin pen. So committing someone to insulin when they don't need it is a really big deal. And sometimes our type 2 ketone-prone diabetes do present the way we would expect a type 3C to present. I often do a CT pancreas on these patients as well, just to check what their pancreatic looks like. If they look like they've got chronic pancreatitis, they've got a low C-peptide, they're skinny, the story puts together, you can tie them over with a little bit of glycoside, but you kind of flogging a dead horse at that point, trying to squeeze out that last little bit of insulin. Inevitably, they're going to need insulin at some point. But if they're really resistant for some reason, or they're reluctant to start, you could give a little bit of glycoside. There's a little bit of evidence for metformin in patients with type 3C diabetes, and that's really in reducing the risk of pancreatic cancer down the track. It's nothing to do with their insulin resistance, but they might have this label of type 2 and come in on metformin. These patients I worry about SGLT2s in because they're already ketone prone because they're insulin deficient, and SGLT2 inhibitors are just masking the problem. They make you pee out your sugar, but potentially you could get ketosis from it. But if someone's not willing to take insulin and the glycoside's not working, but an SGLT2 inhibitor they're willing to take, you've got to weigh up the risk there of diabetic ketoacidosis versus better glycemic control. And that really comes down to, do you think your patient understands the risk of what you're doing? Are they drinking alcohol still, which increases your rate of ketosis as well? Are they fasting all the time, which increases your rate of ketosis? Are they getting regular infections, which increases your rate of ketosis as well, and ketoacidosis? So you need to be quite careful with those medications. And GLP-1 agonists in these patients, there used to be a bit of a warning on the box for people with pancreatitis and not to give GLP-1 agonists. I think if you've got a patient who's not taking any medications and that's the only one they'll take and it works for them, and their reason for pancreatitis is something else, then I think you need to weigh up the risk versus benefit of giving a GLP-1 agonist. And I think there's a place for these medications for these patients if they work. If they're not working, don't give them. If they've got gallstone pancreatitis and they've had their gallbladder out, I don't not give GLP-1 agonists. I think that's a reasonable option in these patients, obviously with some careful education and counselling. But really the mainstay for type 3C diabetes is insulin. And again, it should be treated like type 1 diabetes with basal bolus insulin. And we recently spoke to the government about getting access for pumps for these patients, because they're actually much more brittle than type 1 diabetes, because not only have they lost their beta cells, they've lost their alpha cells. And alpha cells make glucagon, and glucagon is your counteractive hormone to low sugars. And so you can't actually get out of your hypo very easily if you have a hypo. So the range for people with type 3C diabetes is aiming for 5 to 15, and really to keep them out of the low area, because that's going to cause them most of their symptoms. If you've got so much damage to your pancreatitis that you've got this type of diabetes, your life expectancy is not 20, 30 years. It's much shorter. So I don't really care about their macrovascular damage in 20, 30 years. I'm more worrying about their immediate symptomatic sugars. So less than 5 from their hypos, and more than 15 you get polyuria, feel sick and a bit disoriented, etc.
And I've definitely seen a few of these patients on the ward with yourself and other endocrinologists, and they do look really brittle, frail, and they are very young. And they are often co-prescribed Creon to help with their absorption because, as you said, their amylase and lipase functioning is knocked out as well.
10 points. Well done, Indi. And think about that as well. And so the other test you would do is a fecal elastase. And if that's low, then that's pretty diagnostic of type 3C diabetes or diabetes exocrine pancreas. So do get your fecal elastases measured. And remember as well, if you don't get these tests done in hospital, they can't do them in community, because the C-peptide specifically needs to be spun and frozen. They can't do it in community. By the time they put it on a plane to get to town, it's unfrozen, no matter what you do. So those tests need to be done in town. So saying to the GP, can you please retest it, is not useful. And fecal elastases are really hard to get samples of in community practically, and for some reason sending the samples in always gets messed up. So getting that while they're in town is really important as well. So do think about it while they're in hospital under yourself or under your team.
Yeah. Kirsty, is there anything else you'd like to add before we end the podcast?
I want everyone to know that the endocrine team are really friendly and we want to hear from you. It doesn't mean we need to see your patients. It doesn't need to be a big consult. But if you're worried about sugars or other endocrine problems, please just give us a buzz. If we don't know the answers, we'll find out. In terms of deciding whether you want an endocrinology consult versus a diabetes educator consult, endocrinology is really about the medication side of things. How do I change the medications? What's the appropriate medication? And diagnostic dilemmas. Your diabetes educator is more about, hey, this patient's not taking their medication, they don't know anything about diabetes, they're non-adherent, I've started all their meds in hospital, their sugars are perfect, or their sugars are not perfect and I've kind of half started their meds. That's more of diabetes educators. So they can come in and talk to the patients and ask about, access to medications, side effects to medications, history of their diabetes, etc. But if it's more medical medications or they've got comorbidities like renal disease or peripheral neuropathy, etc., those are the ones that endocrine want to see. The other thing is when you get a patient with diabetes, it's really a nice opportunistic time to screen for comorbidities at the same time. I really try and get a urine ACR in these patients. An HbA1c is a good measure, but just check they haven't had it in community recently. You can check that at the moment on the green kangaroo. And then when we get Acacia, hopefully it's a little bit easier to check. The government only funds actually every 3 months an HbA1c, so if it's happening more often, we're sort of just wasting money, but also it's not necessary. I do fasting lipids, liver function test, and ask them about eye checks, things like that. If there's been a change in their eyesight, I always get them to go see the optometrist. If their eyesight's fairly stable, I sort of say just keep on top of it every 2 years. If they've got severe disease, every 1 year. So just doing a really quick screening test for comorbidities. I quickly check their sensation in their feet. People say that their sensation is normal when it's not. And so looking for calluses and abnormal foot structures such as Charcot foot, but even just more subtle irregularities in the foot can tell you that they've got a peripheral neuropathy, and they're not going to feel that tiny stone in their shoe or that cut that they keep walking on, or the bad shoes that they're wearing is getting a blister that's then going to turn into an ulcer and not heal because they've got poor vascular supply to their feet, etc., etc. It's difficult to then prevent the progression of that disease, but knowing about it, you can give some simple education around foot health. And they've made some really nice new foot videos for diabetes, which are now available. They're 2 minutes, they're in language, they're beautifully narrated and illustrated on how to look after your feet and what to do about your diabetes. So that's a really nice resource to give to your patients. There's also a new series of resources for people with type 2 diabetes in Central Australia, based out of the Menzies Institute. So if you look up type 2 diabetes Menzies videos, you'll find them, and there's about 8 different videos. They include youth diabetes, type 2 diabetes in general, type 2 in pregnancy, treatments, etc., etc. And they're quite nice, and they're basically were designed by community at the top end, and there's also some Central Australian people that feature in the videos, so they're a really great resource. For insulin prescribing, there's an app called Thinksulin, 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 and it's really nice when you're on the ward at night. You can quickly chuck in your patient's details and get the right dose of insulin for them, or work out what the next step is, helps you with fasting protocols, etc., etc. So it's quite a nice app as well.
Yeah. Great, and good to know those resources. I think I'll definitely be looking at them as well. Thanks so much, Kirsty, for coming on the podcast. It was great to hear all about type 2 diabetes and more on Desert Docs, a junior doctor's guide to Central Australia. Thanks again, and thanks everyone for listening. Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.